Hello, good evening, sir. I'm Anand from Sun Pharma. Good
Hello,
evening,
sir.
sir.
How are you,
Yes,
Anand?
sir. Fine, fine, sir.
See this.
Th- Thank you, sir.
See this.
Yeah, thanks, sir.
This is a Zoom meet, huh? Is this a Zoom meet?
Yeah, Zoom meet, sir. Zoom meet. Through Dinesh only is doing, sir. Dinesh Pal.
Oh, Dinesh, huh?
His person only, sir. I'll just connect, sir.
Welcome to all the respected delegates for today's webinar. Myself, Amar Sahu, RSM at Vijayawada in Pharmacare division of Sun Pharma, makers of Nizac, Cepodem, Montec Apex. Thank you so much for joining. And at the outset, let me wish a very good evening to our speakers, esteemed panelists. Sun Pharma, the number one pharmaceutical company in India, always wants to associate and contribute to various scientific programs. We keep on doing several live surgical programs and webinars to facilitate the knowledge sharing programs, and we are committed to in future. At Sarfarma, we feel extremely proud to associate with an eminent group of speakers and audience from across the country. We feel extremely happy to continue a series of webinars which we are conducting every month on behalf of AOI branch. Today is the 46th series of webinar. The main objective of this series is to concentrate on basics which will be useful especially for young ENT surgeon and ENT PGs. In each series, we will have eminent speakers and panel members. So today's topic is how to avoid complications in endoscopic sinus surgeries. And today's speaker, Dr. TN Janakiram sir, scholar-based surgeon, Trichy. Welcome sir for today's webinar. And today's moderator, Dr. B. Nageswara sir, Associate Professor ENT, AMC Visakhapatnam. Welcome sir. So I also welcome all the esteemed committee member of AOI State. Our speaker will be happy to answer all questions at the end. Please feel free to ask your questions. Now, without taking much time, I hand over session to Jaiprakash Reddy sir to formally introduce our today's speaker and moderator and proceeding the program. Sir, over to
Hello,
you, sir.
good evening, everyone. Good evening, everyone. As usual, we are conducting this monthly series of webinars for the past almost about 3 years or 4 years from now. So today we have an eminent speaker, Dr. TN Janakiram sir, to share and teach us how to avoid complications during endoscopic sinus surgeries. So I am pleasure in introducing our moderator, Dr. Nageshwar Rao, who is an associate professor and active academician from Vizag. So he'll be moderating this session, and I request Dr. Nageshwar Rao sir to introduce our eminent speaker, Dr. TN Janakiram, and he can start his lecture. Dr. Nageshwar Rao sir.
Thank you, sir. Thank you, sir. Dr. Janakiram, sir, everybody knows about him, but I am just giving little introduction about him. He did his MBBS and MS from Madras Medical College. He is the chief consultant and director, Royal Pell Hospital, Trichy. He is the first author of exclusive JNA in exclusive book on JNA. He is an international pioneer in endoscopic management of extensive sinonasal masses and skull-base tumors. He is inviting and visiting surgeon for more than 15 countries. He is known for more than 1,000 medical camps, pre-medical camps. He is involved in the mucormycosis in the COVID epidemic by the government of Tamil Nadu. He is the best doctor from the government of Tamil Nadu in 2024. He is author of many international national books, and he has created a dedicated volume for this channel that's called ENT Encyclopedia, and several online platforms and webinars for the free access for the benefit of national and international postgraduates. Today's topic is how to avoid complications during endoscopic sinus surgery. I welcome Dr. Janakiram sir to speak about these topics.
A very good evening to all of you. Thank you for your nice words, Dr. Nageshwar Rao Garu. Can you hear me, please?
Yeah, we can hear you, sir. We can hear you.
Okay.
Very clear, sir.
Yeah. I first of all thank the AOI AP State Branch, Andhra Pradesh, for continuously educating postgraduates and also junior consultants by conducting monthly series of webinars. And I presume today is the 46th webinar, and I'm really privileged to be a speaker. I have known the president, Professor Jaiprakash Reddy Garu, for long, and he is a fantastic academician, as I know him. And of course, I thank all the AP state committee members, especially Dr. G. Rakesh, Dr. KBS Kumar Chowdhury, and all my friends, Dr. Krishna Kishore sir, Dr. Janardhan, Dr. Jason Murthy Garu. I have so many friends in Andhra Pradesh, and thank you very much for inviting me as a speaker. So today's lecture given to me is how to avoid complications in endoscopic sinus surgery. In fact, when the topic was given to me, I told the president, Dr. Jayaprakash Reddy Garu, that I'm sorry, I may not be able to talk on this topic because I don't have many complications. I used to, because 30 years back, I used to create some complications. Now, they say after 100 surgeries only you start creating a lot of complications. But of late, I don't have many, so let us change the topic. He said, no, the topic is how to avoid producing complications. Then I said, okay, we'll do that. So let's share the screen and this one, right? Where's these? So Abhishek is managing the screen here. Okay. Can you see my screen now?
Yeah, we can see, sir.
Yes, sir.
Yeah.
Okay.
Hello? Sukumar. Janakiram webinar.
Okay, so how to avoid complications in endoscopic sinus surgery? So you all know the Mosher's dictum, right? The Mosher's dictum says the easiest way to kill a patient is by doing hepatectomy and endoscopic sinus surgery. Because during those days, it was so common, complications are so common. But now, of late, I may not agree with the Mosher's dictum because we have very good training programs, we have very good camera systems, we have navigations, we have very safe instrumentation, and also very good teachers and cadaver dissections all over our country and all over the world. So the incidence of complications naturally reduce. So let me tell you how we can avoid complications in endoscopic sinus surgery from my perspective. Endoscopic sinus surgery is a minimally invasive technique. So actually it's called functional endoscopic sinus surgery, but now no longer it's called functional endoscopic sinus surgery because there are some cases where we are not functional. We become a little radical when it is a revision case. So I can't use the word functional in all cases. So that's why I placed it. Endoscopic sinus surgery is a minimally invasive technique for managing chronic rhinosinusitis and other sinonasal pathologies using a nasal endoscope. So it is popularized basically by Messerklinger. I had the opportunity to visit Graz University, where we had two students of Professor Messerklinger. One is Professor Stamberger and one is Professor David Kennedy. David Kennedy went to US and Stamberger stayed with Graz. And of course, Professor Stamberger died of late. And of course, Professor Wiegand. So Wiegand developed a totally different technique called the Wiegand's technique. And he was from Erlangen. And I had also the opportunity to visit Erlangen. I was the last student of Professor Wiegand. Now, what is the incidence of complication? So incidence of complication actually was, I can only say was because the statistics is slightly old. 1%, that means 1 in 100 develop complications is very high. And minor complications, of course, we see. We see a lot of minor complications, which is 5 to 10%. That also I don't think will be true. But of late, we're seeing a lot of minor complications that because of poor follow-up by the patients or very radical surgery. So, but all these are very high in revision surgeries, extensive disease, fungal polyposis, and of course, skull base erosions. Okay, now the most important point, take-home point, I want to tell the juniors is if you want to avoid complications, you have to plan your surgery. And how do you plan your surgery? With a CT scan. So a CT scan, coronal cuts, a thin cuts. Nowadays we get it in 0.625 mm. So thin cuts, and it's available as a DICOM image. So read your scans very, very slowly and look for very important points which can lead to complications. So I'll just read this scan. So you have to look at all the three planes, but I generally teach looking at a coronal plane because sometimes only the coronal plane is available. Of course, don't plan with an axial plane alone or a sagittal plane alone. It's not good because as you pass the endoscope, the cuts come along the coronal plane. So it's actually passing first cut, second cut like that. But it doesn't happen in a sagittal cut or an axial cut. Only for example, for neurosurgeons, it is very useful. Axial cuts are useful. Whereas for ENT surgeons, mostly the coronal cuts are useful because we pass from anterior to posterior, not from superior to inferior. From superior to inferior is where the neurosurgeons do. So that's where the most of the neurosurgeons, they can't read a proper coronal cut. They'll say, give me the axial cut. And when I go to the neurosurgery department, I'll say, give me the coronal cut. So there's a little conflict between neurosurgery and ENT. So you should always read the CT scan, coronal cuts, and try to reconstruct in your mind both the sagittal cuts and the axial cuts. And what kind of scan do you want? You need a bone window setting. So that's very important. Why do we need a bone window setting? Because you have to see the small bones. Let us read this scan. So the first cut shows the septum. You have to look for the septal deviation and then look for the frontal sinus. So whether it is developed or not developed. So point number one, you should always look for in the scan is whether the frontal sinus is developed or not developed. Suppose you go and poke the skull without a scan. So the commonest mistake is you don't take a scan, take an X-ray and go and operate. That is wrong. In fact, you can be sued in the court of law. And that is the cause for most of the complications if you do it without a CT scan. So the second is look for cells. So the commonest complication which occurs is when you go blindly. Blindly means without a view. You just go and poke into the frontal sinus. That's another very important point. So you have to read the cells. What is, for example, this cell, you can see here it's a type 3 cell. You can see the third cut, first row, you can see a type 3 cell. So another important thing is whenever you look for the frontal sinus, you have to look for the frontal recess. So you're not operating in the frontal sinus, you're operating the frontal recess. So this is what is called the T sign or the M sign. Of course, we are not able to put the cursor here, but I think annotate it. Can I annotate? I'm sorry, I don't know how to do that. It's okay. So here, the frontal recess starts from the fourth cut. Here, it starts from the fourth cut. So look for the frontal recess. And you look for the cells in the frontal recess. And at that point, you start looking for the skull base, which is a Kiros type. I'll be talking about that. So never use a Blakeslee forceps or a suction tip blindly inside the frontal recess. This is very, very, very important. Commonest complication which you can face is, number one is a CSF leak because you're using it blindly. Number two is iatrogenic frontal sinusitis. This is a complication. So it's a complication, but this frontal sinus is normal. If you go and operate and you just poke your suction tip inside, it's going to stenose. And that leads to iatrogenic frontal sinusitis, which is again a complication of this disease. Now, when you look for the maxillary sinus, look for maxillary sinus hypoplasia. There are 3 grades of hypoplasia, and that's called 6 sinus syndrome, and it will be associated with enophthalmos. Look for the uncinate process, where it gets attached. Here, it's getting attached towards the lamina papracia, and so the frontal drainage pathway is medial. So the next thing, so you have looked at the frontal, you have looked at the maxilla, then you have to look for the anterior modular. Look for a supraorbital pneumatization. So the another important complication which can cause is the damage to the anterior ethmoidal artery. So your checklist, number 1, frontal recess. Number 2, type of skull base. Type 1, type 2, type 3. Checklist number 3, anterior ethmoidal artery, whether it is dehiscent or not. Checklist number 4, look for the lamina papyracea, whether it is dehiscent, it is thick, it is thin. So checklist number 4. Checklist number 5, presence of Onodi cell. Any horizontal septum, you can see the second row last, any horizontal septum in the sphenoid sinus is taken as an Onodi until otherwise proved. So you can see here there is a small Onodi on the right side. So you look for the Onodi, and in the Onodi, look for dehiscences in the optic nerve. So these are very so checklist number 1, frontal recess. Checklist number 2. Checklist number 2. Type of skull base. Checklist number 3. Anterior ethmoidal artery. Checklist number 4. Presence of Onodi and presence of optic nerve dehiscence. Okay, and checklist number 5. Lamina papyracea. Correct. So you should look for 5 important things. So again and again I repeat. Number 1, frontal recess and frontal sinus. See the type of cells. Number 2, type of skull base. Number 3, anterior ethmoidal artery dehiscence. Number 4, lamina papyracea, whether it's dehiscent or intact. Number 5, Onodi cell, optic nerve dehiscent or not. Of course, other things, this is called major criteria. This is my own criteria. Another minor criteria. What are the minor criteria? Number 1, you look for from behind, I'll tell. Number 1, you have to look whether the sphenoid sinus is pneumatized or not. Okay, the sphenoid sinus pneumatization, whether it is big, usually one side sphenoid sinus will be dominant, other side sphenoid sinus will be non-dominant. So you have gone first anterior to posterior, you have seen 5 checklists. Then you're coming from behind forwards. Number 1, look for the sphenoid sinus, which is dominant, which is non-dominant. You understand? Now, number 2, you always look for carotid artery. Look for the carotid artery. You can see here, of course, it's not dehiscent in this. See the third row first. That's the anterior clinoid process. This is the anterior clinoid process. 2 eye-like things, anterior clinoid. That area, the bone will be dehiscent along the carotid. So if you look for that, then the carotid can be dehiscent. That's a clinoidal carotid. So number 1, look for sphenoid sinus pneumatization, which is dominant, which is non-dominant. Number 2, look for the bone along the anterior clinoid process, whether the carotid is dehiscent or not dehiscent. Number 3, look for skull-based dehiscences. Skull-based, you saw lamina papyracea dehiscences. Now you're looking for skull-based dehiscences. You understand or not? Number 4, you look for middle turbinate, whether it is pneumatized, non-pneumatized, because pneumatized middle turbinates like concha bullosa can be very thin, and you can actually push it and cause CSF leakage. Number 5, look for the superior deviation of the septum, because that has to be corrected if you want to do a frontal recess. See, I gave you a very nice checklist from forward, behind, from behind, forward, from forward, behind, from behind, forward. Again, I repeat. Number 1, look for frontal recess. Number 2, look for type of skull base. Number 3, look for anterior ethmoidal artery. Number 4, look for lamina papyracea. Number 5, look for Onodi cell, presence of optic nerve dehiscence. From behind, look for which sphenoid is dominant, non-dominant, sphenoid pneumatization. Number 2, look for internal carotid artery dehiscence. Number 3, look for skull-based dehiscence. Number 4, look for pneumatization of middle turbinate. And number 5, look for the septum. So that's it. If you look this one always in the scan, believe me, you'll avoid all the complications. Okay. Now let us go to the next. For example, this case, it's just a scan again. So what are all the things you will look for? Let us see from anterior, posterior, posterior to anterior. Okay. Right side, left side. You should write two sides both. Okay. Now let us start. Now, first is look for the frontal recess. The frontal recess starts from the fourth cut. Fourth cut, it starts, there is a cell here. You can see the cell here. And the concha bullosa is extending into the frontal recess. So, number 1, the frontal recess is slightly narrow anteriorly. There's a small cell above. Yes, you have to take off that cell, but it is wide. Number 2, type of skull base, type 1 skull base. Number 3, anterior ethmoidal artery. It is slightly dehiscent. You can see on the left side alone, right side, it is not dehiscent. Number 4, presence of Onodi cell. Yes, there is an Onodi cell. You can see clearly there's an Onodi cell. Number 5, lamina papyriaceae is not dehiscent. Come from backwards. Sphenoid sinus, the left sphenoid is bigger than the right sphenoid because the node is big. So left is easier than the right to operate. Of course, the second is the carotid artery, not dehiscent. Number 3 is the skull base. The skull base is very clearly not dehiscent. Number 4 is you have concha bullosa on the right side, left side is normal. Number 5 is there is a gross septal deviation, but not superiorly. So I might have to correct the septum to see the frontal recess, or maybe do a middle metal antrostomy. So this is how you avoid complications, my dear friends. If you can read this properly, don't look at the disease. Many people, they say maxillary sinusitis, frontal sinusitis, then sphenoid sinusitis. Who cares? I don't care for the disease. I only care whether I will produce complications or not. So, and then finally, maybe I'll say I'll do a middle metal antrostomy, I'll do a conchoplasty, I'll do a ethmoidectomy on both sides, these are all annex. But the main thing is these 5, front 5, back 5. That's it. After that, you have avoided complications. You get the point? That's it. Don't bother about what is the disease. Disease and all comes next. You understand? Now, let us go to the next slide. All right. Okay. Now, what are the major complications? Major complications are hemorrhage. Hemorrhage is a major complication. Number 2 is CSF leak. Number 3 is orbital hematoma. So if you have a big swelling of the orbit, it's a orbital hematoma. Very big complication is blindness. So in the order I'm putting, first is hemorrhage. Hemorrhage can be controlled. Little hemorrhage can be controlled. Number 2 is CSF leak. Again, it can be controlled, but it's not good. Number 3 is orbital hematoma. That also can be tackled, but it's not good. Blindness, you cannot do anything. Intracranial injury, of course, due to if you go inside and drill off the frontal lobe and debride the frontal lobe, patient is going for coma. Then, of course, you might have in hemorrhage, you can have an internal carotid artery hemorrhage, which is super vital. Then, of course, injury to major blood vessels like internal carotid artery. Injury to nasolacrimal duct is not a very major. Of course, you can do a DCR and preventable. So what are the preventable complications? Number 1, hemorrhage. You can prevent it. You can tackle it. That means you can make it all right. CSF leak on the table, you should make it all right. Orbital hematoma on the table, you should make it all right. Blindness, you can't do anything. You've cut the optic nerve. That means you've not read the Onodi cell. Number 5, intracranial injury. That means you've gone inside and debrided part of the brain. Very difficult to make the patient survive. He might die. Then major blood vessel injury, like for example, the carotid artery injury, the patient most probably is going in for a very major procedure, like for example, coiling or something like that. Of course, injury to nasolacrimal duct, yes, we can do something. Now, minor complications we see very commonly, Synechiae. What is the common cause of Synechiae? Number 1, if you're injuring all the walls of the lateral wall, medial wall, septum, this, that, and make that middle turbinate flabby, that'll be Synechiae. So how to prevent it? You have to give spacers or put sutures or do a bulgarization. Number 2, infection. Infection, you can prevent it, definitely, minor complication. Number 3, orbital ecchymosis. Of course, we have seen this in many cases. If you are opening up the lamina and there's a fat prolapse, you can have an orbital ecchymosis or orbital. So the patient will sneeze. He'll sneeze hard. 3rd day, you would have injured a little bit of the lamina papyriaceae. He'll come with orbital. When you press the orbit, there'll be pluck, 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 pluck sound. That is orbital emphysema. Then additions like Synechiae, hyposmia because you've injured the olfactory cleft, and of course minor bleeding. Of course, we've seen major bleeding too. So stop. Right. Now, surgical principles. So,
Sir, what about that empty nose syndrome, sir, in certain cases?
Yeah, that is very late complication. Very late complication of empty nose syndrome. Done. Yes. Very good point. Accepted. Yes, but there is no known cause, boss. Empty ENF, you cannot get. See, doing it, even doing a septum can lead to an empty nose syndrome. Cutting turbinate, that doesn't come in functional endoscopic sinus surgery. No, that's why I didn't add. It comes in radical endoscopic sinus surgery. It's for radical surgery. Okay. So now, surgical principles. What are the surgical principles to avoid complications? number one, you have to get anatomy. You have to get anatomy. I'll tell you how to get anatomy. The best anatomical landmark is the middle turbinate. Don't ever chop the middle turbinate unless you have a specific reason to chop it. Because always remember, you will not be the last surgeon. Remember this. Number two, the next best landmark is the maxillary sinus. The third best landmark is the ethmomaxillary crest and the lamina preparation. If you get these three, believe me, FESS will be without complications. So three important landmarks. Number one, middle turbinate. Number two, maxillary sinus. Number three, lamina preparation. You get the ethmomaxillary crest and get the lamina preparation. Most of the anatomy you can get through these three. Okay. Number two, important principle. If there is too much of bleeding, no, don't operate. Just go and wait, or abandon the surgery. But don't operate when you have too much of bleeding. And many teachers, they teach using a lot of angle telescopes. Have you seen me using? I hardly use angle telescopes because angle telescopes are the notorious instruments to cause complications because they give a false sense of orientation. That is, orientation is totally different when you use 70-degree telescope. Many people, after a particular period of time, maybe around 100 or 50, 20 to 50 FESS cases, then you can use a 70-degree, you can do whatever degree, even 120, 90-degree I use. But that is after a particular time. You cannot use 90-degree and operate and say you will not produce a complication. Complications are very common with 90-degree. So you have to maintain your orientation. What is the best way to maintain orientation? The middle turbinate. Again, middle turbinate and the septum. Avoid pulling. So another thing is avoid pulling and respect the skull base. So these are all important things. Of course, I have given this as a beautiful thing. All of you should go through this video of how to, follow the 15 commandments. Believe me, if you follow these 15 commandments, you will not have a complication at all. I'm telling you, most of the people, they don't follow the 15 commandments. And that's why. So go through the video. It's there on YouTube. I formed this long time back. So imagine, this is the commonest problem I'm seeing in juniors. Commonest, even seniors I'm seeing. See here, the middle turbinate is lying like a snake. You have to tilt your head to see it. At no point during the surgery you should have this. This is one of the commonest cause for complications. That is camera tilt. So this is very common when you hold the camera. If you hold the camera, this is common. That's why I always say hold the scope. Hold the scope. Don't hold the camera. Number one. Number two is use of angle scopes. If you use angle scopes, very common. This is very common. Never have a camera tilt. They're notorious for producing complications. Number three is it also gives you a false sense of orientation. Now, we will go to specifics now. Of course, I told you 1, 2, 3, 4, 5. In that, I told you the second one, which is the cribriform plate. So the cribriform plate, where do you read this Quiros classification? Many people don't know this answer also. People think that Quiros, you read it in every cut. No, Quiros, the most important cut to read Quiros classification is at the level of the anterior ethmoidal artery. Why? Because the area where the anterior ethmoidal artery enters into the skull base is the thinnest part of the skull base, 0.05 millimeters. And that is where you read because that's where you can easily injure the skull base. Of course, you have to read it everywhere. But what is type 1, type 2, type 3, less than 3 millimeters, 4 to 7 and 7. So, but I always say to my juniors, always treat every endoscopic sinus surgery as a type 3 skull base. Always treat it as a type 3 skull base. Don't treat it as a type 1 and operate. You might see a type 1, but treat it as a type 3. Or you should imagine that the medial lamella is coming down. And this is the distance between the medial lamella and the lateral lamella. Okay, right. Now, the orbit. I told you the orbit, dehiscence of the orbit, the lamina papyracia. That you should understand that if you injure the orbit anteriorly, imagine here, if you injure see the picture down below, the last picture. If you injure the orbit down below, there's a distance of 1.5 centimeter at the level of the nasolacrimal duct, just behind it. Distance between the lamina papyracea and the muzzle is roughly around 1 to 1.5 centimeters. So even if the fat comes out, there's no problem. But as you go behind, you see the muscles are very close to the lamina papyracea. So if you injure the lamina very close to the orbital apex, the chance of diplopia is very high. Okay, so this is very important. So even if you injure that fat comes out anteriorly, don't worry. Optic nerve and the medial rectus injury are common when you hit the posterior ethmoid and go back. Okay, so this is very important.
Sir, for the juniors
Hmm.
or beginners in the surgery,
Hmm.
what is the best position of the head of the patient to prevent injuries?
Yeah, I think that is 15 commandments. I'm not talking about it because
Okay, sir.
all that you have to see the 15 commandments, all that is given in 15 commandments. I'm
Yes.
telling, apart from that, I'm telling all that.
Yes.
So I request a very good question by Dr. Professor Nageshwar Rao Garu. Read the 15 commandments very, very, very clearly, because each position is very, very important. I have clearly described all the 15 commandments and how you have to do. Unless you follow the 15 commandments, neutral position, you should always have your head in neutral position. Never have it in extended position. Extended position, you will go into the skull base very easily. So all that is there in the first 15 commandments. Okay. Now, sphenoid sinus. So sphenoid sinus, CC, I told you, anterior clinoid process, there is a optic nerve and you can see the anterior clinoid process. So you can see the Onodi cell here very clearly. And you have to look for the optic nerve dehiscence there. If you look for it, then naturally you will be very careful there. Now, you always look for these five, as I told you, you look for Kiros 3, dehiscent, carotid artery, all that 10. You always form in your mind, what is the risk factor I have in this case? Of course, halar cell is also like concha bullosa. You have to look for halar cell. You have to look for Herzella cell. That is a posterior ethmoid front ethmo-orbital cell. All that you have to write down in a notebook. Before you start the case, you write down in a notebook what are the red flags in this case. Then you start the case. You understand? Very, very important. So let us discuss each complication, how to avoid such complications. Let us see hemorrhage first. So the commonest hemorrhage you will see is a mucosal hemorrhage. Mucosal hemorrhage. So a lot of bleeding. Immediately what you will say? You will tell the anesthetist, boss, reduce the BP, boss, reduce the... So please understand the pulse rate, the mean pulse rate should be around 60. And 90-60 will be the ideal pressure, blood pressure. But you cannot decrease that for hypertensive patients. So what I usually do is you have to put the patient on beta blockers. Beta blockers is the best. You have to put it 1 day preoperatively, 25 milligrams of atenolol, and if the patient is a non-asthmatic, and that will reduce the pulse rate to 60. And that will give you beautiful control of bleeding. Point number 1. The second way to avoid bleeding is raise the head end. If you raise the head end around 15 to 20 degrees, the blood pressure will come down 10 millimeters of mercury. So you can actually raise the head end. Number 3, what you can do is use packs. Use packs between every step. What are the packs you will use? You can use whatever you want. I use pressure gauze because I feel it's good. Of course, some people use Merosil. I mean, that's just whatever you want to use. But you have to soak it in adrenaline, 1 in 1,000 adrenaline. And number 4 is you can irrigate with warm saline. So keep irrigating. Irrigating. If you irrigate, bleeding will reduce. Pack, bleeding will reduce. Mucosal bleeding will reduce. And then finally look at the anesthetist. Please reduce the BP. And then he will reduce it. Okay. So these are all the ways.
In what way the warm saline is useful for bleeding, control of bleeding?
So warm saline acts by extrinsic pathway of hemostasis and it activates it and thus reducing bleeding. Okay, but
What is
warm
the meaning of
should
warm
not be
saline,
too
sir?
warm. It should be at 40 degrees.
Yes.
40 degrees. You should not be too warm. Don't put hot water. Hot water will cause vasodilatation.
Yes.
Just want to know how much time I'm given for this lecture.
No, sir, 1 hour, more than 1 hour, no problem, sir.
1 hour. Huh?
No time limit, no time limit, sir.
I have just 20 minutes more. It's okay.
No, no problem, sir. You can do it. Sir, one more doubt here. So
Ah.
you said you have to use concentrated adrenaline 1 in 1,000 for packing.
Yeah.
So for a normal endoscopic sinus surgery, how many ampules of adrenaline you can use safely?
See, this is a common question asked by everybody. How many ampules I use? See, adrenaline packing causes intense vasoconstriction. What happens? You pack with adrenaline, it will cause vasoconstriction, thus preventing its own absorption. Whether you use 1 cc or 10 cc or 100 cc, the minute you pack it, it's going to cause vasoconstriction. And after that, where is the absorption? There's no absorption. So that is why Stamberger says unquantified, undiluted adrenaline can be used. So some people say, when I say 50 ampules, 50, what's the, whether it's 50, 30 or 10, it's going to have the same action because it will produce vasoconstriction, it will not get absorbed. So please understand, this question is being asked in many, many conferences. I think this is not to be asked because of Stamberger's beautiful statement of undiluted, what did I say? Unquantified, undiluted. So you don't have to quantify the amount of ampules. So that because it already produces a complete vasoconstriction. So don't infiltrate, my dear friends. This is very, very important. If you infiltrate, you will see the pulse just shooting up, the BP just shooting up. So don't infiltrate. It's just topical packing. And of course, when you topically pack on a bleeding surface, it will just stop. But you should not pack it on exposed dura. If you pack it on exposed dura, you can have ischemic changes. Very, very important. Now, the next is major bleeding. Of course, I have abandoned some, when I started, I used to abandon some pediatric polyposis because of excessive bleeding. Excessive bleeding, I was like, it was more, there are different methods to rate bleeding. You know, there's a PG Ormold's rating of bleeding hemorrhage. So you just read it from Professor PG Ormold's book. 1, 2, 3, 4, and all this we have. Type 4 bleeding, it will just pour out of the nose. It's very difficult. Or if the patient's on blood thinners, so you should stop the blood thinners 5 days before. Then only you should take the patient for surgery. Okay. Now, next is major complication like hemorrhage. You hit the sphenopalatine artery. So this is, I think, is not a big problem, but you can prevent it by identifying where this artery is. This artery has got many branches. You can hit the posterior septal branch. You can hit the main artery. You can hit the inferior turbinate branch. You can hit the middle turbinate branch. All these can bleed. I'm just going to show you one such case where we had bleed. See the bleeding here. So what do you do? So you see that's a bleeding from the sphenopalatine artery, posterior septal branch. So what I do is I take a coblation there. I take a coblation. So don't panic. The main thing is you can pack it also. You can pack it. Now, the minute I use, so I always advise that, see, I'm doing a sphenopalatine artery ligation on the table. So on the table, see, that's a sphenopalatine artery. So that's it. You ligate it. You use the blue and then the yellow. Never use it towards the foramen. You understand? If you use it towards the foramen, it will retract and go inside. So again, see, what you have to do is, whenever you have bleeding like this, don't panic. What is the first step you will do? Take an adrenaline soaked pack and pack it. Once you pack it, it will automatically stop because of vasospasm. Because there will be vasospasm, it will stop. Believe me, it will stop. But here, I'm just showing you that we can do it with coblation. Always have a coblation band whenever you do FESS. In our center, have I ever done FESS without coblation? Never. Because you can have any bleeding. You may have dural tear, you can just put coblation there. So these are all, sorry. So again, I'm just going to show you this very nice case so how do you prevent this? Preventing is you should know the anatomy, and of course you should not use a debrider on that area, and you should not widen the sphenoid os inferiorly. If you widen the sphenoid os inferiorly, you can have this bleeding. So how to prevent this? This is a posterior septal branch. So you can have so if it happens, what do? You just have to use coagulation, or you can just pack it with adrenaline, and you can just coagulate the sphenoparatine artery. That's the sphenoparatine foramen. You should know the anatomy. For that, you should know the anatomy. Okay, now I'll just show you a case of a sphenoparatine artery ligation. You see, that's the inferior turbinate. This is the inferior turbinate, the middle turbinate. Just make 2 incisions, one above the inferior turbinate, that is with the coagulation, everything with the coagulation. So that is the middle turbinate, and this is the inferior turbinate. Just make that incision clearly, beautifully make that incision. See how I made that L-shaped incision, and then elevate. See, that's sphenoparatine artery. Very simple. And then pull it and coagulate it towards the middle turbinate, That's it. Once you coagulate it towards the middle turbinate, it will stop. That's it. But please remember, there can be up till 18 foraminae. There can be till 18 foraminae. That's why we go till the level of the anterior wall of the sphenoid sinus and coagulate. You will coagulate one and it will bleed from the other. So you should understand that. Okay.
Now you are doing an ablation mode or coagulation mode?
You first use only the blue. You make a marking with the blue, and then slowly go for the yellow. Blue, yellow. Just keep changing. So never use the yellow because it will start bleeding. Use the yellow.
Yes, sir. Okay, thank you.
Use both alternately. Now, second is anterethmoidal artery injury. This is a dangerous thing. How do you avoid it? Avoiding is, number one, is you read the scan. Look for the dehiscence of the anterethmoidal artery. If it is dehiscent, that means you have a mesentery. Then you should not use Blekkersley on the skull base. You should not use debrider on the skull base. You should not use any instrument to pull. Don't use it to pull. If you cut, it's okay. But if you pull, what happens? It retracts into the orbit and produces orbital hematoma. So how to prevent? Identify artery in the CT. Avoid aggressive superior dissection. And always have coagulation with you. This is the easiest way to avoid. Let me show you one video. This is a very, see, this is a case of AFRS. So you see here, what I do is, I'm just using the debrider. All steps of surgery are not being shown. You can see the skull base on the right side. Now, this is the right side. See what I do. This is my own case. See the anterethmoidal. See. You should read the scan. See, both sides anterethmoidal artery are dehiscent, and there's a massive supraorbital pneumatization. Now you know that it's dehiscent, but see here, that's the anterethmoidal artery. Very clearly see. Anterethmoidal artery. The right side anterethmoidal artery. See that? See, I'm going behind. Behind, cleared, and then what happens? Anterethmoidal artery is fully seen. See that? It's fully seen. See the anterethmoidal artery. Now, if you pull the anterethmoidal artery, what will happen? It will go inside the orbit. If it goes inside the orbit, what should you do? This is another thing. You should also learn how to tackle a complication. Avoiding a complication is there, but how to tackle a complication. The first thing you should do is, see, the debrider is being used on the skull base. Let's see. I'm using it. This was around 10-15 years back. Just see here how I do that. I am very casually using the debrider. I'm not even bothered. So, see that. See what happened. That's the anterethmoidal artery. Can you see that? But see what happens to the anterethmoidal artery. See, I'm just going to show from the beginning till the end. So that means how to avoid it. Don't use debrider. You understand? Don't use debrider is the way to avoid. See. I'm just showing you what happened to this artery. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34. So why I told that seconds is because, see, there are various areas where you can cut the anterior model artery. Now, let us see this. Okay, you can cut it here. You can cut it here, or you can cut it here. Please understand, there are three areas where you can cut. If you pull it here, this will go inside. But if you cut it here, okay, this is a bone. It goes into the bone. See, anterior model artery comes via the orbit, comes out through a foramina, passes like this, and then goes into the intracranial cavity. This is bony canal. This is bony canal. Please understand, if you cut it in the middle, there is no bone. Okay, so it will stop. On its own, it will stop. Because vasospasm. But if you cut it here, if you cut, not pull, if you cut it here, this is bone. Okay, it will prevent this bone to artery from vasospasm. It will keep bleeding. That's why I told the number, it was keeping on bleeding. So if this is not bone, it will stop. Same way here, if you cut, no, it will not stop. But even if it retracts, see, if it retracts, you can ask me, if it retracts in the intracranial cavity, what will happen? You should understand the intracranial cavity, even if it retracts, it is going to stop. The problem is it will stop. If it retracts, it will stop. But the thing is, the volume of the orbit is less.
It cannot expand.
All the walls are bone. So it cannot expand, it will compress on the optic nerve. The problem is not bleeding. The problem is compression on the optic nerve. Whereas if it goes here, it produces extradural hemorrhage. No problem, it will stop. But it will not cause any dramatic complications. It will go to resolve later. Okay, the problem is when you pull and this goes into the orbit. So don't pull. That is how you prevent the. See here, this what do you do? Always have a coblation. See, what do you do when you see in this case, first thing is you should press the eye. You should immediately open the eye, look for the pupil. Okay, whether pupil gets dilated. Number two is press the eye for tonicity, whether it's becoming hard. And then third is raise the head. You're going to close the bleeding. Don't put an incision and search for the artery. You understand? And then what you do is call an ophthalmologist because you need medical legal. So better you call an ophthalmologist. He's not going to do anything, but call an ophthalmologist. Before he comes, what you do here is that you see here, if it has gone inside, what you do is you remove this lamina papacia. You remove this lamina papacia and make a cut here. If you make a cut, the orbit comes out. That's it. The volume has increased. Nothing will happen. We have had at least 10 bleeds. We cut the anterior model artery wantonly because skull base, I'm a skull base surgeon, right? So I cut it wantonly. So what I mean to say is, even if you cut it, don't worry. You just have to do a medial orbitotomy. So here I'm using a bipolar. So do not be rash during surgery. Do not use debrider or pulling instruments on the skull base. Do not panic seeing a bleed. Many people, what they do is they panic. Oh, bleeding. Nothing will happen. Only carotid, you have to panic. Anterior model artery, you don't have to panic. Look for retraction of the artery into the orbit. If not, just cauterize with bipolar and always look for supraorbital pneumatization so that you can prevent this complication. Okay. Now, the next is catastrophic hemorrhage. So what happens when you have catastrophic? So what is the commonest cause for catastrophic hemorrhage? Carotid artery. IMAX, even sometimes the IMAX can cause very heavy hemorrhage. So both you would have seen it. So how do you prevent it? Don't use debrider inside the sphenoid sinus. If you use inside, you can use it only in the anterolateral wall. Never use it inside. Number two, when you remove the tumor, don't pull. Don't pull the polyp from the sphenoid sinus. You might have a dehiscent carotid. Number three is revision cases or irradiated cases. Okay, so if you want to prevent a carotid artery injury, don't pull the intersphenoidal septum. Intersphenoidal septum most probably gets attached to the carotid artery. MOCR, medial optical carotid recess. So you have to look for dehiscent carotid, look for onodi cell, extralateral instrumentation is a problem. So how do you prevent it? You, if you're not sure, use navigation. It's easy. Now see, I'm going to show you one case like that. See what I did. So these are all my cases. See, this is of course, this is the 16th revision JNA or the 14th revision. It is not endoscopic sinus surgery, but see what we do. So this is a bleeding. This is from the, so I'm using scissors. And of course, I don't want to go into the technicals of this. So I see that now. So this is called, what is called the red dot. It's called the red dot. Okay. So what do you do when you have a red dot? So the first step you have to do is pull your endoscope out. Pull your 0-degree endoscope out because your endoscope is already fogged, right? Immediately your left hand should go towards the bleeding site. Your left hand has got a suction, goes towards the bleeding site. And put the suction directly on the bleeding. Like a pipe is going to, then after anti-fogging, put your endoscope. Okay, put your endoscope. Then what you do is put the suction and nicely press it on the bleeding site. So it acts as a stent. You understand? Nicely press it. It will stop. Immediately the right hand, what happens is you should ask somebody to hold that suction. Take fat muscle from the thigh. So use a quadriceps muscle. See that you're just putting a pack. You can put a pack. It's called the Swiss roll technique. And of course, you can put that. We put a muscle there. Once you put muscle, crushed muscle releases myosin. And myosin is a powerful anticoagulant. And it will stop the bleeding and immediately shift the patient to a interventional radiology. So this is why it has occurred. You see, I'm using debrider inside the sphenoid. See, this is inside the sphenoid. Don't go inside the sphenoid with a debrider. See the bleeding. So never do that. Sphenoid, mucosa also is vascular. You will not know what is happening. Now CSF leak. CSF leak is a major complication. The commonest cause for CSF leak is using instrumentation without seeing, without visualization. So how to prevent it? You should visualize. For this, we need angled telescopes. So the only area where you need an angled telescope is the skull base, especially the frontal recess, and use a 70-degree telescope. All of you should practice 70-degree telescope, and that is very important. And don't use suction tips or upturned Blakeslee. If you use that too on the medial wall means toward the skull base, can easily penetrate it. And you will have a CSF. This is what will happen. You'll have a CSF leak coming out. And once, of course, this is post-op. So, but if you see a CSF leak, it's clear fluid, immediately you have to repair it. Okay, how do you repair it? So how do you...
Sir, what are the conditions that confuse the CSF leak during surgery?
Yeah, number one, see, before that, I'll tell this prevention. Always identify the skull base. I will not put 30 degrees, 70 degree. Gentle ethmoidectomy. Avoid superior pulling motion. And respect asymmetry of the ethmoid. And always think that anteriorly it is superior and posteriorly it slopes down. So if you're unsure about it, use the Bulla-up technique. But I prefer using a Stamberger technique. Identify the planum and come back. If you identify the planum and come back, you are very safe. Now, Professor Nageshwar Rao Garu has asked one question. You can mistake certain conditions for CSF leak. Number one, you irrigate the frontal sinus. If you irrigate the frontal sinus, and if the frontal sinus orifice is narrow, it will come like a bottle. You take a bottle, fill it up with water and invert it. It will resemble CSF. You get chills. I'm telling you. When I started my surgery, I got chills seeing it. I thought it was CSF. Then you should have the anatomy proper, and then go back to your scan, read it, and then do it. So that is very important. That's a good question. It's called the inverted bottle sign. Okay, now how do you manage? You have to manage it on a graft. Of course, use multi-layer, fat graft, fascia, but you have to do it on the table. Don't postpone. Don't give Diamox. Call your friend. If you're not sure, call your friend and ask them for help. Please understand that. Okay, right. Now you can see here, of course, this is, this is a endoscopic sinus surgery. Of course, this is a case of series of leaks, but see how you can repair it with the adult flap or whatever. So just, okay. Now, orbital complications. So in orbital complications, the commonest is fat prolapse. So anteriorly, when you injure the lamina papyracea and go inside, the fat will come out. Don't worry. Okay, if fat comes, in fact, in some conferences, some people will be operating, they'll say, sir, fat is coming, then the demonstrator gets really annoyed. I mean, in the sense they get scared. Don't get scared. You can stop. Don't pull fat. You should not use the debrider. Usually the M5, debrider blade, very powerful. That can cause a little injury. The minute you see a fat, you get chills because you will think that orbit has been damaged. Patient will develop, nothing will happen. What did I do that day? I just used bipolar and so you just have to use bipolar and push it inside. That's all. So next is medial rectus. Once you have gone inside, you can produce diplopia, and that can produce restricted motion and can produce diplopia. So you can see here that is a patient having diplopia, of course. Now, this is orbital hematoma. So what happens is, if there's an ethmoidal artery injury, a lamina papyracea breach, then you can have so all this, how do you prevent? Read the scan. Don't use Blackesley or M5 debrider blade right on the lamina papyracea. See whether it's dehiscent. And if you actually injure it, stop. And then gently pack it and come out. Gently. The problem in this is it's an emergency. You might have it popping out, the eye popping out. If it is seen in the table, you do orbital decompression. But if it's seen in the ward, what you can do is you can do a lateral cantholysis, inferior orbital. Okay. So you have to give steroids and then you have to open up the orbit. Now, optic nerve injury is really dangerous. I have not seen one actually, but I've heard that people have produced it. That means the patient, the surgeon should not do any surgery, boss. If he is going beyond the medial rectus, then beyond the fat, then going into the optic nerve and cutting it, believe me, then only problem is the Onodi cell. If Onodi cell you have dehiscence, then it is dangerous. Don't pluck inside the sphenoid sinus. So optic nerve lesions is common. You see here, this one, I got it from the net only. So very common. No, I think this is my case, but this is trauma. Okay, nasolacrimal duct injury. This is very important. This is seen when you do anterior widening of the middle meningeal. So basically, nasolacrimal duct drains into the inferior meatus, and it is just anterior to the ancillary process. So when you use a backbiting, if you bite very hard, how to prevent it? When you see a little bone, then stop. Don't bite. If you bite, patient will have epiphora. Okay, but actually the epiphora stops if you irrigate. If you imagine you have injured it. Okay, you know you're injured it. You know you're injured it, then start irrigating. Irrigating from the eye, punctum. So you will form a tract. You understand? That's the best way. You can put steroid also in the eye, to the eye. Okay. So how to prevent it? Don't do anterior widening, preserve the inferior turbinate and all that. Okay. Now, intracranial complication is a dangerous complication of endoscopic sinus surgery. I've seen one case which was done abroad, and they put the debrider, upturned debrider into the frontal, through the frontal into the frontal lobe, and debrided a little bit of the frontal lobe also. Patient developed pneumocephalus, patient was in coma, patient died. So that will lead to meningitis and all this stuff. Now, minor complications, Sinecate. Today morning also I showed one nice case of brilliant case. You saw it live, right? Sinecate. The best is you have to suture. So to prevent it, suture the middle turbinate or create bulgarization. And we have now clips by the some company, you can put clips. So then you put silastic stents, all that you can use. Of course, you keep your pack for some more time. All this you can do. See this Sinecane today morning case. This is today morning case. Post-operative bleeding. Of course, I've seen this massive hemorrhage. I was called to Hyderabad by a doctor. Do you know this? And I had to go by flight to tackle the doctor's complication after FESS. Patient had massive epistaxis. I went there and I saw that the doctor has injured the internal maxillary artery. Through FESS, went inside the posterior wall of the maxilla while doing an MMA, injured the IMAX, and that was bleeding like crazy. They just got me an emergency from Trichy, and I like it. I just want to tell you that there can be post-operative bleeding too, especially when the turbinate is cut. The inferior turbinate is cut. Be careful. So don't cut turbinates generally. Hyposmia when you do olfactory cleft. So how do you prevent it? Preserve the superior turbinate. Too much of resection of superior turbinate can cause hyposmia. So gentle dissection near the cribriform plate and maintain the olfactory cleft patency. Of course, infection can lead to. So when you open up the orbit, imagine that you have fat prolapse. Always put the patient on very high antibiotics. I have seen orbital cellulitis. Patient develops after 2 weeks. Sudden increase in size of the eyeball, severe pain. That is because because the lamina papyracea has breached, the periorbita is breached. So naturally, the patient's good layers are gone. So the patient will develop orbital cellulitis. So you have to irrigate with saline antibiotics, and of course, put the patient on very high antibiotics and steroids. So risk factors for complications are revision surgery, distorted anatomy, extensive polyposis, of course, skull base, and you need a lot of experience. How does experience come? Only by cadaver dissection. And most importantly, your mentor. Your mentor should be teaching you what to do. We have fantastic mentors who are teaching nowadays, like Dr. J.P. Reddy sir, and of course, Dr. Nageshwar Rao Garu sir, and everybody who are actually propagating knowledge. And so I'm sure that we can avoid complications. So CT evaluation, 3D anatomy, gentle tissue handling, stop if disoriented. If you're disoriented, stop it. Stop the surgery. You don't have to complete it. Stop it. The enemy of good is better. The enemy of good is better. You want one cell extra into the frontal and land up with a CSFD. Don't do that. Now, never hesitate to abandon or call your seniors, and you need adequate training with cadavers. Of course, I just want to show you that. Hi, this is Dr. Janakiram. We're going to see you. So when you handle your, of course, this is available on YouTube. You can see that, how gently we do it. So I always say FESS is like corneal surgery, like cataract corneal surgery. And if you handle these tissues nicely, see the uncinate, how nicely you're able to take all that. So when you handle it gently, with finesse, you will not have any complications. So I'm using a bulla up technique. See that how I'm gently taking off the Aganasi. That's the Aganasi. See, we can do layer by layer dissection. See that? That's the frontal which has been opened. So this is like, I'm telling you, this is like eye surgery. Don't go and, debride, pull, pluck. All that is butchery, not surgery. So if you can avoid all these complications by being fine, by knowing your anatomy, by doing a lot of cadaver dissections. So prevention is better than cure. And I really thank AY AP branch for this wonderful opportunity which they have given me. And I really appreciate your patient listening. Thank you very much.
Sir, we have little time, sir, for a few minutes with the permission of our President, Dr. J.P. Reddy, sir.
Babu,
So,
hello?
sir.
Yeah, there are some questions that we need to take, actually.
Yeah, please.
Am I seen? Am I audible?
Yes, sir, you are.
Oh, yeah, tell me, please. Yeah, I can take
Somebody is asking, what is the partial middle turbectomy, when to do that, and how to prevent lateralization of the middle turbinate.
See, when the middle turbinate is very hypertrophic and you're not able to enter into the middle meatus at all, it is completely paradoxical. You can do what is called the wedge resection, a small wedge resection of the anterior end of the middle turbinate. But the problem is can lateralize. So you should suture that remnant middle turbinate or bulgarize it and stent it, or else this is going to lateralize later. 3 months later, I've seen lateralization. So most of it try to avoid. If you have to do it, but try to stent or suture the middle turbinate.
The next question is, so what are the most reliable landmarks to identify the natural ostium of the maxillary sinus?
Natural ostium of the maxillary sinus. See, the best. Can you see my screen share now?
Yes, sir, definitely. Cadaver comments.
Yeah, I'm just going to show you. Hi, this is Dr. Janakiram. See here. Now I'm just going to show you where this is the middle meatus here. Okay. Now this is the uncinate process, free border of uncinate. Okay. So you see, this is the free. This is the best frame here. This is the best frame. This is the bulla. Okay. So this is the uncinate process. This is the upper 2/3. This is the lower 1/3 of the uncinate process. This line is an imaginary line which cuts through the upper 2/3 and lower 1/3. This triangle is called the Nix triangle. NIC.
Yes.
So when you open this is Professor Sethi always used to teach backbiting, Nagashima backbiting. If you open this and you push it down, you push this like this, then you will always, this is the infundibulum. You can see the infundibulum, the deepest portion of the hiatus similaris. And you can see here, that's the hiatus. See what I do. Now I'm just trying to, now you can do what is called the, see the natural ostium, very clearly seen. That's the uncinate process which is being removed. And submucosal dissection of the uncinate. Use a 30-degree telescope now. And there is easily, you can see the natural os. That's the natural os. So you can widen the natural os. See that? So the best landmark I can say is the Nix triangle.
Sir, can I add one point, sir, here? Can we draw an imaginary line under surface with the bulla or on the lateral side that exactly corresponds to the natural?
No, wrong. See, bulla has got variable attachments.
Sir.
Something called the low attachment of the bulla, which sometimes bulla will go into the maxillary sinus itself.
Yes, sir.
Yes, sir.
So many times you have seen that. You don't use that as a landmark. That's not a good, reliable landmark. You might not have a bulla at all, torus bulla. Then
Yes,
you cannot say that as a landmark at all. The best is the uncinate process, the lower third of the uncinate process.
Now somebody is asking, please suggest a very good book for the endoscopic sinus surgery.
We have many books. Professor P.J. Ormond's book. Best till today is Professor Stamberger's book.
Yes, sir.
I will not recommend any other book. You have to get that book. It's like Bible. Read it 10 times, 15 times, 20 times. The book. Stamberger textbook is the book.
Sir, what is the best to pack the nose? Either it is a nasal splint or a merosil in post-operative FESS, somebody is asking.
Sometimes we don't even pack, boss. It depends on what you do. If you have done some radical surgery, the best is luminized merosil. Luminized merosil is the best. Of course, now a lot more packs are coming. I use Posicef. Posicef is a superlative packing. I got it from Dubai. I use that. That's absorbable. Nasopore was there once. I don't know if it's available in India now.
No, nasostent is there, sir. This is actually Smith and Nephew,
So
sir.
that is super.
Prevents any care.
That's super.
Sir, and how to avoid syncytial formation in the post-operative FESS and septoplasty surgeries.
Best is follow-up. If you do proper follow-up, ask the patient to douche nicely. If you find soft exudates, you just suck it off. You will not have syncytial. And don't traumatize the nose when you're operating. Too much of trauma, medial, lateral, and all, you will cause syncytial later. So number one, gentle handling. Number two is when you see post-op, you should have a regular follow-up. So for 5th day, 10th day, same way, 2 weeks, 6 weeks, like that, you should have a proper protocol for you. And then you have to, so when does the syncytial start forming? Syncytial starts forming after the 4th week. So you should be the first 4 weeks, if you properly manage the nose, you will not have syncytial.
Sir, when do you do first suction clearance of your ethmoid or mid-layer
1 week.
meatus following surgery? 1 week, sir? Yeah. So that we completed all the questions, and there are some people who come from Jordan and some foreigners also actually.
Thank you very much. It's a great
Thank
honor
you very
to-
much, sir. It was a pleasure to have you. Actually, it was our dream to have you long back, but today it has come true, and we are very happy. And then this was a topic that we wanted to have, because complications, once the complications have occurred, we have to treat them. But
Yeah.
preventing complications and knowing them to prevent is the most important thing. So we have had a right person today, and I thank Dr. Janakiram sir for having us here for 1 full hour or more than that. And we wish to have you many more in the days to come, sir. Thank you very much.
Thank you, Dr. Janakiram, sir. Thank you, Dr.
Sahu,
JP Reddy, sir,
Sahu.
President AY.
Sahu,
Sir.
you shall
Sir.
vote of thanks.
Hello.
Vote of thanks
Yes, sir,
from
yes,
your
sir.
side. Yeah.
So, yes, sir, yes, sir. So, good evening once again, all the respected delegates of NISAC. Once again, Amar, this side of Pharmacare Division of Sun Pharma. So, today's session was really very wonderful. I give heartfelt thanks to today's speaker, Janakiram sir, for a very impressive talk, guidance, and making this evening very enriching in terms of knowledge. I also thank today's moderator, Nageshwara sir, as well as JP Reddy sir, for navigating the entire session wonderfully. My heartfelt thanks to all delegates for attending today's webinar. On behalf of Sun Pharma, makers of NISAC, Sepodem, and Montec FX, I'm sure today's discussion will ultimately benefit several patients. Thank you for giving us an opportunity. As
Sir,
mentioned in the
about,
beginning, we have planned a
300
series of
logins,
webinars.
sir.
So today we have completed
Almost
yes, sir,
300
yes, sir.
logins.
Very correct.
And till now,
Wonderful,
now
sir.
there are
46
about,
series of webinar we
yeah.
completed today. 300, sir.
yeah.
So such a big series of webinar till date continuing for years with the help of AY State and JP Reddy sir. Before close the session, we will request to try our nasal spray NISAC FT, which is a fluid fluid coming with a different way. It is a 360-degree pump system as well as repriming free device with your next patient who are suffering from allergic rhinitis. We'll soon come back with the next schedule of webinar of the series. Thank you, sir. Thank you, JP Reddy sir. Thank you, Nagesh sir. Thank you, Rakesh sir.
Thank you,
and all the-
Raman. Thank
all the
you.
panel members. Thank you, sir.
Thank you,
sir.
JP Reddy Garu. Thank you, Nageshwar Rao Garu.
Thank you, Dr. Satta. Thank you, sir. Namaste. Thank you, Dr. JP Reddy, sir, President AY. Thank you, Dr. Rakesh, Secretary. Thank you, Dr. Kumar Chaudhary, Scientific Committee Chairman. And the executive members of this APAY, we wish the same after few sessions, after few months again from the same faculty. Thank you very much.